Here. Van
Here.
Hopper. Here. Webb.
Okay, I believe we have a quorum. Moving on to the consent agenda. Does anybody wish to make a motion in regards to the consent agenda? Okay, I would make a motion that we group 1 through 22, and that we approve items 1 through 22 on the consent agenda.
I'll second that.
We can call for a vote?
Well, hang on just a minute.
Sure.
Okay, so 22. Now, I've got a question. Which one of these, and I looked at it, but I forgot to bring my copy. Which one of these dealt with not getting paid back if you had to go drive somewhere and get something for the hospital?
That was.
Did anybody else see that? It's kind of like if, and y'all can correct me if I'm wrong. If you drove less than 25 miles to go pick something up, then they would not reimburse your mileage. So if they sent you to Granite, to pick up a drug from the pharmacy, then whoever they sent would not get their mileage. And is that,
That actually has been removed.
There's 100 miles.
Yeah, it was 100 miles. They've decreased it to 25. They've removed it even further where it's any mileage, you do get reimbursed now.
okay.
Yep.
Well then, if that's how it is, that's good, because, come on now, I mean, some people out there that you may send, they may not even have enough gas money, much
Right.
less not to get it back.
And that's why they went through and removed that.
Okay,
Yep.
good.
What's our liability on that, though?
Which part?
About them going and getting it.
About them driving.
About them driving their personal vehicles and insurance of the company, of the hospital.
They're
If I-
responsible if something happens. If there's a car accident or something in there, it depends on whether they're on the clock or off the clock.
So you're saying the hospital would be liable?
They should be clocking out, but then they can't clock out because they're doing hospital business.
Right.
So if they're on the clock, the hospital is responsible should they get into a motor vehicle accident between here and, let's say, Granite Pharmacy.
Yeah.
Then the hospital is responsible because they're on hospital time doing facility business.
I don't think that's always the case though, because I had a bunch of home care people and they drove their own cars all the time and they signed a waiver and we kept a copy of their
Right, that's a little bit
insurance.
different though. They are conducting business, but a lot of them also had a commercial vehicle, and when they don't have a commercial vehicle, they accept that liability on their own because they're doing home care and
Right,
they need
but-
their
but
transportation to go
anybody
to
who-
and from. This
anybody
is a
who-
little bit different when you're sending someone to go pick up a
But you
prescription.
can require that from anybody who
Yes.
you would ever
Yeah,
ask
but
to go on it.
Without it, they
Yeah.
are responsible.
Yeah.
Well, that's interesting.
Which is probably something we should do.
Yeah.
Anybody who's going to be asked to go, keep a current insurance.
Currently do not have that at this time. We can work with Chief, she's on the call, so here's what we're talking about, we can start working on something like that.
Who do we have on the call today?
Chi, Dennis, who's finance, Chi is paralegal for us, and then Cindy.
Okay.
So at this time, I believe we do have a motion and a second. If we could call for a vote at this time, that we group items 1 through 22 together?
Lively,
Yes.
Ford,
Yes.
Van Zandt,
Yes.
Hopper,
Yes.
Okay, moving on to item number 23, November and December financial reports.
Okay, I'm gonna be going over the financial summary from the December board packet because it has both November and December on it, if you guys wanna follow along. Okay, the November average daily census was 8.07, and December was 8.19. This is about 3 days down from the 2023 year-to-date average. The acute payer mix for Medicare and Medicare managed care for November was 75%, and December was 87%. The year-to-date swing bed payer mix is 90% for Medicare and 10% for Medicare managed care. The operating margin is a loss of $143,000 for November and a loss of $225,000 for December. The year-to-date amount is down about $56,000 from the monthly average for 2023. Net patient revenue was $1.2 million for the month of November and $1.1 million for the month of December. 340B revenue was $17,000 in November, and it was the highest it's been all year in December at $49,000. The revenue for all of 2023 was $192,000. Operating expenses were at $1.39 million for November and $1.45 million for December, which is down $68,000 from the year-to-date monthly average. Patient days for November were 242 and December was 254. Both are quite a bit lower than our year-to-date monthly average of 344. Cash receipts for November were $985,000 and December was $930,000. Cash disbursements were $1.35 million for November and $1.19 million for December. Cash balance at the end of November was $1.14 million, which is about 24.7 days of cash on hand, and December was $892,000, which is only 19.1 days of cash on hand. Moving on to the clinic, the average visits per day for November were 8.89 and 8.75 for December. Revenue for the clinic ended at $397,000 for the year, and operating expenses were $875,000. That resulted in a net loss of about $478,000. Okay. We move on to the budget.
Okay.
Do you have any questions?
When you look over that loss, is that just due to not sending out statements?
No. So most of that loss is because cohesive AR is growing. So if you look at it on a cash basis, you guys have cash, and you're making a positive, EBITDA at the end. But if you look at it on an accrual basis, which is how we do the accounting, it's the cohesive AR is growing, so that's what's putting you in the negative. Dennis, do you have any other thing to add to that?
I'm sorry, I couldn't hear the question from here.
Cheryl, what was your question again?
Oh, I was just asking if the deficit was from not billing
Is the
sending
deficit from not
statements.
sending out statements, or what's the loss? What all is it from, is what she was asking?
We had, as Adrian said, with two of our lower day census that we've had in some time, so it's not just, Medicare is not impacted as much as all the other payers, but that's one of the primary drivers of that piece as well.
For the clinic?
She's talking about for the clinic, Dennis.
Oh, for the clinic,
Yeah.
no. I don't have anything else to add other than what Adrian commented. The best thing, one of the best things to note is that was the highest 340B revenue month. And again, the great thing about this program is that there's just no offset to it. It's not one of those things where you have to spend $100 to get back 85. You know, profit is profit, it's cash, like it would look like a normal business that you think of. So everything that we can do to grow that piece will can only help. And I will tell you, we've got one facility that, one clinic that just touched or reached a goal of over $1 million annually in 340 revenue and net cash profit of approximately $510,000. So the sky's really the limit on that. I hope this really blossoms that way in Maine this time.
Yeah. That is what I was wondering about. Okay, so it's looking as if we're just keep rising and rising and rising in cost, especially I would assume that Cohesive is the one that we're most indebted to,
Yes.
then we're gonna have to, obviously, whatever's going on is not working. You know what I mean? So what's the solution for that?
Dennis, do you want to give them what you've told me before about the Cohesive? I mean, we have the markup.
Yeah,
Can you
the short version on all these good classes, hospitals, and I'm probably preaching a sermon on this, but it is unfortunately the way we are reimbursed, and Medicare is our biggest payer. And I don't know how to sugarcoat anything, I'm pretty direct on that piece. And when Medicare is your best payer, and they're only paying, say, 85 cents on the dollar, and others are paying worse. Well, the only way to do that, or to make this, is we're doing everything we can to try to keep things stable as possible and try to make improvements from one year to the next over time. I will tell you, at some point in time, I physically, I don't say I'm going to preach it here, but think that Congress or someone's going to have to change the way critical access hospitals are reimbursed. I've pulled so many cost reports from so many facilities, I can't even count them all. And they all have major losses. They're paper losses to some degree. And from a cash standpoint, you know, you can't go below zero. And that's why, in some instances, if we couldn't pay something within a full year, we had to put it in a note. We're trying to pay it over time. But at some point in time, the system's going to have to change the way they are reimbursing critical hospitals. And I think with Medicare managed care, that might happen sooner than later. But it's going to have to happen at some point in time. And that's why you'll see when we get to the budget, we do an accrual basis budget, and we do a cash basis budget. And cash basis budget is what physically happens. The accrual basis is what the accounting piece is. You know, and the short version too, Cheryl, is that 100% of just about everyone else's invoices, all the vendors get paid. You know, as far as that, we get a big piece of ours paid, but we don't get 100% of ours paid. So everyone else, every invoice that you'll receive from every vendor has their cost plus their profit. And if they have 50% profit or whatever, well, they get 100% paid. And we try to always pay the local vendors and keep everything local if we can. So we get paid a percentage of our profit, but not 100%. We're the only vendor that don't and doesn't, and that's why we've been kind of the bank. And the other thing too, not to regurgitate history, but you know, paying off all those ERS debts and everything that we incurred or inherited, and all that interest and everything else, that didn't help matters, and that puts both behind to start with. So, you know, all these critical access hospitals are swimming with one arm tied behind their back. That's probably one of the better analogies I can give you.
And the best thing that can happen is to get more patients out there, more Medicare patients. That's really the best
Yeah, well,
way
it's
to.
smart,
Yes
smart
and no.
growth, you know,
It's a very tight road.
and by that, what you're looking for, and what what I've been example, we've done this in places just recently, but your therapies, in some instances, we've looked at some things where we've got an opportunity to physically get paid more by our non-Medicare payers than we have. So those are the rare exceptions that few and far between, but it's just a lot of strategic moving of pieces and everything else to make the most of what the hand that they offer.
Is Cohesive currently happy with the current state of the hospital in terms of its growth and financial health at this time?
Compared to everybody else that I've seen, I can say that, and where Mangum was a long time ago, it vastly improved, from that position. If you were to ask me about critical access hospitals and how the 20 years from now or 10 years from now, I don't know the answer to that. Like I said, Carson, I think something's going to have to change at some point in time, but right now, most important thing, especially for these communities, is keep these hospitals alive, keep them functioning, and we try to strategically find every single dollar you can in every corner. We have a group of reimbursement people, and that's all we're doing all the time. My whole history has been finding EBITDA.
So-
No matter what you found, I try to find some way to improve what you have.
So you touched on a subject right there that I would like to circle back on. You said we need to find every dollar possible, right? That we can.
Right, you're trying to find what I'm meaning by that is you're trying to find every smart growth opportunity possible.
What about collecting money?
I'm sorry, say that again?
Collecting money
Well,
from the
revenue
recipients.
cycle, we've done a really good job on that piece. Not 40 years ago, I remember when I first started.
But if I don't get a bill for 2 years, how can I pay you money?
Did you hear that, Dennis?
No, I did not.
If I don't get a bill for 2 years for the 2 years I've gone to the clinic, how can we get every dollar? I mean, those are dollars that could help benefit Cohesive.
I think that's, certainly has been fixed. I had a procedure out there right before Christmas, and I've already gotten my co-payment bill in the mail from Tulsa.
But what my concern is I've just gotten bills from 2 years ago from going to the clinic, in that I think we hit December and we sent bills, but if we're not doing that for 2 years, these are revenue dollars that we're not even attempting to collect. So that's a percentage of money that, if I go to the clinic and you guys get $15 and then I owe another 35, that's a lot of money to get us closer to being at a smaller loss.
Well, if you haven't received a bill in that long a period of time, we need to collect or something, that's a breakdown in our revenue side.
But that's my concern here, is that we may have a fundamental breakdown in our billing cycle, and maybe even just as simple as looking at switching our billing system to something switcher and to pull in more revenue dollars. Because while Medicare is great and we like those patients, there's a percentage of the population that is going to be private pay or commercial insurance. And if we're not collecting on that, we're leaving money on the table. And that can help pay back Cohesive some of these funds and get you paid down quicker. And so my fear is that we're leaving years of money, because the likelihood of getting paid after 2 years is greatly diminished. We have 90 days to get paid, to where we drop to almost 50%, if not.
Now, do people get collection notices and collection calls?
I personally got a collections call. I mean, I haven't had confirmation if that was real or not, but I did get a collection call the same day I got a bill in the mail.
And collection calls, I've talked to Lori about that, the collection calls and our billing department in the hospital and the clinic, and the collection calls should have not have started yet because of the approval that we did, the bill
Exactly.
to go out, the last final letter. I'll talk to you a little bit about what happened after
That's-
this.
yeah,
But, yes, you will start getting collection calls after all those letters went out. I will tell you, business office just sent out, they've been sending out about 90 to 100 a week of the letters saying, you owe us this amount of money, pay us
But-
within this time.
My point is, and I'm not upset, I'm not anything, my point is though, if we hire a collection agency, we just lost either 25 to 55% of the revenue that could have just been fixed with a what, I don't even know what they charge now, 45 cents or 50 cents on a stamp in an envelope. That if we had a good system of sending bills automatically, that we could be generating income. Because if I owe $110, but you hired a collection agency, we just cut our collection by $55.
I will say, I do think some of that's been fixed with ECW. Now,
Okay.
CPSI, that's what the clinic was using prior.
But that's been over, how long, Cheryl? Over a year, 2 years?
Yeah.
I mean, that's been over,
ECW's been there a little over a year, yeah.
did we just turn something, I mean, I don't, again,
Not
I'm
for
not,
ECW. For ECW, I will tell you in the hospital, yes, a button was missed and people weren't getting bills like they're supposed to.
okay.
Uh,
But we've corrected.
We have corrected that, yes.
Okay, cool.
And the clinic should be they send out bills every, I want to say Thursday or Friday, they do a bill. They do a run, both with the team, Tricesto or something, does that billing for us.
Okay.
And they send out the bills, we don't have to physically do anything, they do it all.
Yeah.
But hopefully with ECW, I know that was 2 years ago, and over the last 2 years of seeing them in the clinic, we'll have to check with Jessica why you weren't getting them.
Okay.
Well, Carson, I'll add one. You're exactly right. Anything like that, we're responsible for that. That's ours. That falls under our watch. And I would personally look into this piece. I mean, I wasn't aware of what you're talking about.
Yeah.
But
Disconnected.
Hey, on record, I did not hang up on you. But I'm not upset, I'm not angry about this, because it's an easy way to fix that I think we can pull in $100,000 to $125,000 of extra income a year.
Hold on 1 second, Dennis.
It's really not extra, it's just what's due.
It is what's due, but it would be,
Extra this time. yeah.
it would be, it is what's due, but it's less than what we would lose. And that's an easy fix.
all our hospitals get it the sum of the parts. So even if it's a small dollar, it's the accumulation of all the small dollars that from current people and very.
Hold on, Dennis, real quick. Hold on. We lost, our Bluetooth capability, hold on.
You read on it? I don't know, that thing is over there.
Smartphone connected.
I
Okay,
wonder if
Dennis,
we got too far
go
away,
ahead,
like,
start.
it's like too far impaired. Yeah.
I was going to just say, I repeat myself, I apologize, I was saying, Carson, you're right on target. And, that falls under our watch, and any breakdown, on any aspect, we need to follow up and fix it immediately. And it's not, no matter, even if it may seem like small dollars, it's the accumulation of all these small dollars that add up to something material. And as a manager, since we're the last paid, we're also doing it in our own deficit. So I can't argue with you whatsoever. You're right on target. I will personally look into it tonight. I wasn't aware of that.
Easy fix, and hopefully it'll increase our revenues, you know, that's, you know, good amount, so. Maybe we can get bigger TVs.
For where?
The hospital room.
We just bought new TVs. We're
They
not-
need like 80-inch.
Oh, my God. No. Yeah.
Hey, I saw a TikTok at a hospital in New York saying this guy had like a 72-inch.
It's fancy.
That's awesome.
Bring your own.
Yeah.
Add that to the ambulance. Wait, get my 80-inch. Yeah. Okay,
You ready to go over the budget?
I'm ready.
Gotta
See,
move the budget.
All right. I'm gonna go over the budget assumptions
We've got,
first.
we're gonna have a budget this year?
yeah.
Yeah, Kelly and I worked on it, and so did Dennis.
Very good.
Great. All right. The assumptions for the 2024 budget, so we have an average daily census of 11 versus our current year of 11.33, which is about a 3% decrease. We have budgeted the payer mix allocation consistent with the current year. All other stats have been budgeted based on the calendar and/or business days. 2024 has a leap year day, so both the calendar and business days has increased by 1. Our shop estimate has actually gone up for 2024. It's going to be $827,727, which is a $134,000 increase from the current year. And all salaries and benefits and expenses were reviewed and budgeted at the department level by Kelly and I. And I'll just quickly go over just the high points of the accrual basis. We have gross revenue budgeted to be $26.3 million for 2024, and operating revenue ending at $16.6 million. Expenses are coming in at $17.5 million, which is down about $216,000 from 2023, mostly because of salaries and contract labor, which is due to the budgeted decrease in patient days of 109 from 2023. And the budgeted net loss for 2024 is a total of $1.87 million, which is an increase actually from the current year of $135,000. And if you guys want to dig into any of it, or go over the cash one, we can as well.
And you just said a loss of 1.8 million? Now, always before, it was like you couldn't accept a negative budget. Is that still correct?
So that's an accrual-based one, but we also have a cash basis, so I'm
Okay.
not sure if which
Okay,
one
alright.
has been
It's
presented
the
in the past.
cash basis.
Yeah. they-
Okay.
yeah.
Right. Yeah, EBITDA for the cash basis is $902,000, and of course, the net income or loss is 0 for cash.
And that's not very realistic, but.
That's what we adopt, is the cash basis, yeah.
Okay.
That's what we adopted last year as well.
Okay. Yeah, if you guys have any specific questions about it, just let me know and I can dig into it further.
Thank you.
Moving on to item number.
We need to adopt the budget.
Oh, okay.
Motion to approve.
Do you need them separately? or both?
We just need to adopt the
Just
cash basis, yeah.
Okay, I would make a motion to adopt the fiscal year 24 budget on the cash basis.
I'll second it.
We can call for a vote at this time?
Lively,
Yes.
Ford,
Yes.
Bazant,
Yes.
Hopper.
Yes.
Okay. Moving on to item number 26. Presentation of the Mangum City Regional Medical Center audit from CLA.
I think that just needs to be tabled now.
Okay?
We're pushing it to have it done by then, I think.
Okay. Moving on to item number 27. Discussion of possible action to approve
pharmacy consultants consulting agreement.
This is just our pharmacy consulting group that helps us with 340B compliance. They help us with mock audits every year, if you look at how much it is. And they also help us make sure we're collecting all of the availability of 340B that we are looking at, all of our contracts with our local pharmacies and everything we're sending in. It's just something we have to renew every year. The price did not go up, prior cost. Again, they did a virtual audit already this year, and we do one yearly, and then any other help that we need.
We can make a motion that we approve item number 27, the pharmacy consultants and the consulting agreement. We may call for a vote at this time.
Lively,
Yes.
Ford,
Yes.
Van Zant,
Yes.
Hopper,
Yes.
Motion carries. Moving on to item number 8.
28.
Excuse me, 28, discussion possible action to approve the memorandum of understanding between the Mangum Regional Medical Center and the Oklahoma Department of Mental Health and Substance Abuse Services.
This is just an MOU, a memorandum of understanding with us and them, for them to provide us Narcan for free and us to be able to hand it out to those people of high risk through the emergency department and the clinics. It's no cost to us. They supply the medicine for free. We just have to monitor how many we're giving out. That's essentially it. Again, I think we talked about this a little bit. We don't, the only demographic information we have to have is zip code that they live in and age group, like 26 to 30. That's it. We don't have to have any personal information whatsoever, so.
And I'm gonna ask that y'all table this item, because the issue that I have with some of these agenda items is that it's not real clear what the memorandum of understanding is. So these agenda items aren't meeting Open Meeting Act requirements that a person of normal intelligence can read this agenda item and know exactly what y'all are voting on. And so so this is gonna apply to a lot of these. So this one needs to be tabled.
Great.
Okay.
Moving on to item number 29, discussion possible action to approve the hospital ministers to sign the agreement of MRMC, Master Service Agreement, and Clifton Larson Allen LLP.
This is 2930 are the two agreements that CLA has sent us that y'all had already approved for us to do the 2018-2019 audits. They just sent it to me with my name on it, just for me to be able to sign them electronically so they can begin work on those two documents.
And again, this agenda item is not sufficient to meet the Open Records Act because it does not tell the general public what the master service agreement is. So this item needs to be tabled.
Okay, moving on to item number 30, discussion and possible action to approve the hospitals administered to sign the agreement of the MRMC Statement of Work Agreed Upon Procedures with Clifton Larson Allen LLP.
Same announcement.
Yeah.
Okay.
This is one reason why we need the agenda early enough so that we can work out these kinks before they get posted.
How early do you think you need the agenda items?
Well, I mean, normally we try to give them Wednesday at noon to give us a couple days to work it out.
do you want him to send them to you?
Yeah, I sent it
Or-
Wednesday at like 1:30.
Okay.
I mean,
It's
And
just-
I got it
I mean,
to you,
they
but
used to send them on Fridays. I mean,
Yeah.
I sent them on Wednesday. I mean,
That's part of the
I don't
wording,
know, I
does
mean-
he need to be sending that to you?
we need to fix the wording is what I'm saying.
Yeah.
I'm fine with that.
Okay. Moving on to item number 31.
Because basically, people of normal intelligence has to be able to read this item and say, oh, I know exactly what the hospital board's is gonna vote on tonight. Not, what does that mean? And then we passed it. I mean, it could say memorandum of understanding that we're gonna go kill 100 puppies. You know,
Is it the entire packet uploaded though, where people could read that?
that's
memorandum?
not part, that's an agenda item.
Okay.
It's an
I'm just
open meeting,
asking.
it's an
Just
Open
asking.
Meeting Act requirement.
Okay, I'm just asking, because these, I mean, is that a new requirement?
It's been like that for a long time.
We just hadn't been doing it though.
We have been doing it. We have been doing it. So,
What about item number 31?
See, this one, we got to approve the hospital administrator, MRMC life share for organ and tissue, so we know what this agreement's for. But I would not tell you to agree to it, because I don't think y'all need to delegate your authority to the hospital administrator to sign things on y'all's behalf. Because that's why we just got done selling and about a multi-million-dollar lawsuit, was because the previous hospital administrator was signing stuff on our behalf.
So in regards to this, when we make this contract to Life Share, is there absolutely anything that you guys get from Life Share?
Absolutely not.
Okay.
Extra work when someone passes.
Okay,
Yeah.
so my question is like, why do you, what's the incentive onto
You
it?
have to, it's a CMS requirement for organ procurement,
Why?
to give people, to be able to donate life to other people. That's it. You have to have an agreement for CMS, so if somebody
But-
is a organ donor, you have to have a organization that is specialized in that to be able to come in and get that tissue and.
But let's be
organ.
real,
Mhm.
that's not gonna happen in Mangum.
Well, no, but they come and get tissue, absolutely. At
Sorry,
funeral
I'm
homes,
gonna
not in
go,
the hospital.
I know, I'm gonna go on my mountain and die. But my issue is when people are called after their loved one passes and their 90-year-old relative who smokes and drank and is not a candidate for organ donation gets a phone call from, "Hi, we're with the organ sharing group and we would like to talk to you." They think they're giving their heart and lungs that are life-saving measures when in fact they're taking skin and tissue and bone. But my point is just like, why are you guys required to do, anyway, sorry, I'm going down a rabbit hole, you don't need to go down. It's tabled anyways. Are we tabling or are we just voting no, Corey?
Well, because the only action that could be taken is to approve the hospital administrator to sign it.
Okay.
And I don't think y'all should let the hospital.
advice of-
administrator- If they're written contract for you to approve, y'all need to sign it, is what I'm saying.
Okay, I would like to make a motion that, for us to call for a vote on item number 31.
Did you want them to sign the agreement?
No, that we want to,
But that,
It's-
but the agenda items is to approve the hospital administrator to sign it.
so can we, like, call for a vote and vote no, we don't want this to say that?
Yeah, you can do that.
And say, we want it to be reworded in the Mangum Regional Hospital Authority.
I'm sure they have a standard agreement, don't they?
Yes.
Well, there is a standard agreement.
Yeah, it's attached.
You tell them they need to call the funeral home back within 60 minutes.
Yeah, good luck with that one.
Yeah, and not tell families they'll be back in 12 hours. Okay. Do we just want, you guys want
Can't
to
you just
table
let
this?
it lie and then they come back? I mean, it'll.
Table it, if we
it'll
have it?
to be, I mean, that's what
Yeah,
he's.
gotta reword it.
Okay. What about item number 32? Discussion and possible action to approve MRMC Aetna Better Health Hospital Agreement.
Well, 32 and 33 is identical.
Provider clinic, it's 33.
One's hospital, one's provider.
But the agenda items, this 32 is discussion and possible action to approve the MRMC Aetna Better Health Hospital Agreement. Okay, and the health part, okay, I see it, okay.
There's two different agreements there.
Again,
So we have 3 agreements, though. We have the,
One's for the rural health clinic, one's provider, one's hospital, but they're all worded the same.
Yeah.
Minus the hospital provider, RHC. That's the difference.
okay.
But it sounds like Corey's saying that those do not provide enough information to meet the Open Meeting Act to determine what's actually being discussed. Unless I misunderstood.
we just need to have one parenthetical says this is what this agreement does on the agenda.
Okay. So we're gonna table 32, 33, and 34 at this time?
This could affect your reimbursement from Medicaid, I'll just tell you that. Because these are new managed Medicaid agreements. So you probably want to start February 1st.
So are you sending copies to the city?
Absolutely.
If you've got the copy, I don't understand what the
I don't
problem is,
understand
Corey.
it
I'm
either,
sorry,
because
I'm sorry.
we-
Please enlighten
this
me.
is
I
how we worded
understand
these
it's the
this whole
wording.
time.
It's the wording,
But-
yes.
Chi, have we worded these any different in the last, since June, since I've been here, we have not worded, the Blue Cross Blue Shield agreements that just went through, were not worded any different.
Right, we typically state the vendor's name and then the name of the agreement. And then, in verbal discussion, we would explain what the agreement provides.
So if a member of the public wanted to see it,
It's there.
Look, I'm just telling you my opinion. You don't have to take my opinion, but I'm just letting y'all know that my opinion on these. So if y'all want to pass them, y'all can.
It's, hey, y'all are the board, I mean, I'm just here to facilitate the meeting a little bit.
I think the general public is aware that Aetna deals with insurance.
So what, just out of blind curiosity, what would be said under, so we would say discussion possible action to approve MRMC, Aetna Better Health Hospital Agreement, and then like in parentheses, this is an agreement between, like, or what would you say there to clarify it?
Just what the agreement does.
So we're gonna summarize
Wait, just-
27 pages.
There's a new case that came out recently about language on agendas. It involves the city of Norman and where they adopted a budget. It went all the way up to the Oklahoma Supreme Court, and because it actually reduced funding. And because it reduced funding, the Fraternal Order of Police filed a lawsuit against the city of Norman and basically said, even though it was adopted budget, and it's been adopted budget for 150 years, because it did not specifically say and notify the public that it was going to reduce funding for the police department, the Oklahoma Supreme Court sided with the Fraternal Order of Police and ruled that the agenda item was unclear.
Okay.
So there is new case law. The Open Meetings Act has not changed, but there's been new case law that has came out that wants people and entities to have clear language on the agendas.
So Kelly said it's 27 pages, so obviously you can't summarize 27 pages in a little parenthesis bracket, so how would you do it? Would it have to state something, this is to affect the, reimbursement for Medicare patients or for the new managed Medicare programs?
Something similar, yes.
Okay, just curious how you would shorten 27 pages.
All three of them, please,
Right.
yeah.
But if you just need a little bracket that says it will affect Medicare reimbursement for the new Advantage programs.
So you could say Medicare, affects Medicare reimbursement. Next item is Blue Cross Blue Shield's payables.
Yeah.
Next
I mean,
item
if-
is,
And if I would've known that more wording would've needed on these on Wednesday, I would've beefed up my agenda, but I didn't know that.
so,
I think we can, I can, my conscience will allow me to vote on these three in particular, just because I know that they're payment rates, and it's something that we need to get approved for the new year, to get reimbursed. So I will make I'll make a motion that we accept 32, 33, and 34 based on what's written. And make improvements in the future.
I will second it.
okay, let's call for a vote.
You have to vote on them separately, though.
Oh, okay, so let's do
So
this
we're dealing
first.
with 32?
32. Okay, so I have a motion, I have a second, if we can call for a vote at this time.
Lively,
Yes.
Ford,
Yes.
Elizabeth,
Yes.
Hopper,
Yes.
Okay, item number 33, discussion and possible action to approve the MRMC Aetna Better Health Provider Agreement. Just for clarification real quick, can you give me a real quick summary of what this does mean?
On
What the
RT.
EdNet,
No, we're on
Provider.
33 for the provider.
On 33 for the provider, that is just the agreement between the providers and Medicaid. Essentially, Aetna's, Medicaid is being broken into 3 different managed Medicaids. Aetna, Humana, and Sooner Select, okay? So we're gonna have to have agreements with all 3 of them, because now with the portal that's opening in February 1st, everybody that has Medicaid is gonna have to re-enroll. And that eligibility on which program they go into is gonna be based on that enrollment. So you're not gonna be able to choose, I want Aetna, I want Humana. They're gonna place the person there, and then you have to accept that insurance. This is just enrolling the provider, so when we bill a provider's fee for services, they go through the credentialing process. They look, make sure they haven't had any claims against them, any false claims, anything like that. So this is to say that provider is credentialed with us to be able to bill us for their fee services. That's all this is. So you got a facility and a provider fee. So this is the provider fee, so every provider has to be, well, they don't have to be, you can choose not to take Medicaid. But that's all that's telling you. And you're gonna get paid this much for your fee for service.
okay,
Lively,
Yes.
Ford,
Yes.
Van Zant,
yes.
Hopper,
Yes.
What do you want to do about who called? I don't think we had a motion for
I
that. Do you
don't
just
think we
want to
did.
Separate motion.
make a separate motion, and you can list me as making the motion, and then
Okay.
somebody else?
I just remember Michelle saying she was gonna do all 30, sorry.
Oh, okay, is that
Sorry.
cool? No, as long as we got somebody for you to check the box, then.
I had her and then Hopper for the
Then you can do all
22nd,
three.
23rd, or I'm sorry, 32nd,
Okay,
33 and 34.
cool. Okay, moving on to item number 34. Discussion possible action to approve the MRMC Aetna Better Health RHC agreement for the Mangum Regional Medical Center. I believe we have a motion on the floor and a second. At this time, let's call for a vote.
Lively,
Yes.
Ford,
Yes.
Van Zant,
Yes.
Hopper,
Yes.
Okay, moving on to item number 35. Discussion possible action to approve the MRMC Evidence Subscription Service Agreement. Addendum adding communication center.
If we gotta put more, I'll.
Is this a tablable
Yes,
item?
this is a tablable item, yes.
Okay.
100%.
Okay, we'll table it. What about this one, Corey? About the discussion possible action to approve the FH 224 budget accrual basis, does that?
We
not
don't need to
enough
adopt the
information?
accrual. We did the cash basis above,
Okay, cool.
so.
Okay, moving on to the item number 37, discussion possible action to approve a calendar year 2024 meeting dates.
I'll make that motion to approve the,
I was gonna say I saw those. but-
included
I saw those
meeting
there.
dates. I noticed
Yeah.
that the December meeting was on, was before Christmas,
Yeah,
right?
it was,
Oh, you guys don't want to do that Christmas?
No, we don't
second.
wanna do that again. Sir.
I'll
Okay.
second.
Okay, if we could call for a vote at this time?
Lively,
Yes.
Ford,
Yes.
Van Zant,
No.
Hopper,
yes.
Item number 38, discussion possible action to accept the FY 2021 audit completed by CLA LLP for the period of December 31st, 2021, submitting the audit in accordance with the applicable state statutes.
No action, we don't have it?
I was gonna
Okay.
say, was that the other ones?
Yeah.
Moving on to item number 39, medical credentials and contracts. I make a motion that we approve.
Well, now, hang on, do we know about all this? I understand the credentialing, but the contract.
Hold on, I got that for you.
Do we need to move into executive session before we do that?
I mean, if y'all wanna discuss it, it's not, we can. Contract, so that's her contract.
But do they need to turn off the audio? think it's fine without it.
The only reason, again, we don't upload those to the packet is because it has compensation in it. So
Sure.
that's why we don't upload it. So it's there if y'all wanna get 18 pages.
Tua, if you just give us a minute to look at this, there you go.
For her, I guess you go over what, Doctor, I go over Corey, since we're still open, can I go over what her contract is for?
Generally.
General, okay. That contract for Dr. Fay is to provide, oversight for the Strong Minds program, to start getting that stuff in place so we can begin Strong Minds at our facility, which is a outpatient mental health.
Who's the target audience for that?
The geriatrics, 55 and above.
Okay, so we're not talking about any that are currently in the nursing home, or we are?
Yes,
Okay, well, has our relationship with the nursing home improved?
it has started to improve, yes, ma'am.
Okay, because this just, to me, seems like fluff. I'm just stating my opinion. We're already in debt, we keep climbing, the debt keeps climbing.
I think we need to go.
Well,
I'd like
if-
to make a
well,
motion
that-
that we go into.
Okay, time out. This is just to discuss personnel and contract matters. So if there's anything outside of that scope, we don't need, we don't need to go into executive session to discuss that. The executive session is only for the employment, okay?
Okay.
So I just want to be very clear before we go in there, into executive
So
session.
we cannot discuss our like or dislike of the Strong Minds program. We can only talk about this particular contract.
Yeah.
We cannot get into a debate about Strong Minds and.
Okay, well, if we're gonna have to talk about this contract, we needed it before a minute ago to be able to talk about it. Just me.
So there's only the one contract, the rest of these were just credentialing?
Yes,
Okay.
the rest of those are just the DIA radiologists.
Okay, and this is strictly for the psychiatric care
Correct,
of elder individuals,
correct,
which may or may not be in the community.
yes.
They might live at the nursing home, or they could be in the community.
Absolutely.
Correct.
Yes. They, the way it works, the way the Strong Mind programs work is we have a van. We are responsible for going to pick them up. So we have a person, go to pick them up, a tech, to drive a van, and we don't.
We already have a van?
No, ma'am. We have to buy one.
We're gonna have to buy a van.
Correct. We gotta get a van, in to go pick up patients up, bring them to the facility. We will have a licensed counselor, psychiatric counselor there, most of the time, 3 days a week. These people come 3 days a week to the facility every week unless it's holidays or bad weather. We provide them a snack, we provide them lunch. Again, they get to interact with one another, and then we take them back home after lunch. It's usually from a 10 to 2 timeframes when we have them at the facility. Currently, we're working with the architect out of Wichita Falls to look over, to make sure, when I say working, he's just oversight, to make sure our area will suffice. Because we gotta move physical therapy and put the Jerry psycho physical therapy currently complete as that. So as soon as he says, yeah, your functional plan's good, to send to the state, that's the next step, is getting our functional plan to the state.
Are we like way out of bounds?
No.
We're okay?
Good, this is the background, whether you want to approve a contract for that program or not.
Okay, so is this person's sole benefit for that program?
Yes,
Do we start paying them
not till
before?
the program starts.
Okay,
Not till the program starts.
Okay.
We don't start paying them, say, next month.
okay.
It starts when the program starts.
So the program isn't official yet. You have architects looking at the space, then you have to send to state for approval.
Correct.
Do you have any idea how many people potentially would be participating?
Uh,
Assuming everything gets approved and everybody's happy.
We would hope anywhere, looking at the numbers, 3 would be minimum, every 3 days a week.
And what's the reimbursement for you guys? Because we know pretty much some of what the
Yes.
outlay is gonna be. So what's the reimbursement?
Right around 350 per visit, 350 per patient per visit.
Okay.
So, that's looking at what they're close to reimbursing.
So if you have 3 days a week.
Yeah. Yeah. 3 of them, 3 days a week.
And overall, positive financial impact for the hospital is that it is almost 100% for the most part Medicare utilization. And in this instance, even though it basically just barely, it doesn't cover 100% of its cost, but it pulls other overhead into the equation that Medicare will reimburse. So in this instance, this is one of the rare things because it is so heavily Medicare. At the end of the day, when the dust settles, the net reimbursement overall for the hospital, even though the program will be positive, overall for the hospital it will be. So it actually has a positive cash impact overall.
Is there a
One of the
time?
rare few things.
So if we sign the contract though and we don't get the program off, are we still obligated to pay this person?
How about this comes back whenever the program is
Ready to go.
ready to go?
Is there any sort of problem with that? Like,
Cindy, I don't know if Cindy's still on there, there's no, if they wanted to table the contract until we're ready to go, as soon as we hear from the state, is that okay?
Yes, that would be fine.
Okay, we can table that, so.
Cool.
We can table this contract.
so I would like to make a motion that we re-credentialize.
No, those are initial credentials for the DIA.
I make a motion that we credentialize these individuals, just credentials, no contracts.
Okay.
I will second that.
And then we table the contract.
Okay.
This time if we can call for a vote, please.
Lively,
Yes.
Ford,
Yes.
Azant,
Yes.
Hopper,
Yes.
Can we also actually have an item on here where you in-depthly explain this program,
Mhm.
the cost, what all's involved?
Yes, ma'am.
Corey, now would this be another example of that we should have had out there? New contract, strong minds, on this like contract here,
Since it's an employment contract, that's,
separate? Okay.
We could do, I'll do a discussion in the thing of what Strong Minds is and give you,
Yeah.
I know we have a pro forma out there, Adrian and I worked with, for the Strong Minds program, we'll get that together, get that to you.
Because I think there's only 2 board members that have ever heard strong minds before.
Well, we had a clunker purchased of a van before.
Yeah.
And nothing
Okay.
Yeah.
came of that, and it was just,
In
that
fact-
was just a costly tool.
Okay.
Yeah, I mean, I think this, when I came on the board, the strong, everything that we were going to move up to the Strong Minds program was tabled because of COVID.
Yeah.
And then, so it hasn't been talked about in 4 years now, so we probably do need an update on
Okay,
what it
absolutely.
means.
We will get you a refresher.
Okay, I'd like to make a motion that we move into executive session at this time to hear item number 41.
I will second that.
If we could call for a vote?
Lively,
Yes.
Ford,
Yes.
Azant,
Yes.
Hopper,
Yes.
Do we need to go?
Y'all want us
No, I'm just teasing. I'm just teasing you. I don't know.
I don't think they do.
we need to pause the recording? I just saw it still going on.
Leading, I think, just to say that they're all filled, because it makes it appear that it's core staff. So maybe on the next one, it could be separated that you're still utilizing X number from each discipline,
Yep.
like RN, LPN, whatever staffing nurses you use, to list out how many are still staffing agency versus core staff.
So if we have RNs and they had come to you right now, are you gonna say we have no positions available?
Yes.
Okay, so, but we're gonna pay monthly $141,000 to a staffing agency in which we could be out promoting to hire local RNs at a less expensive rate for RNs, LPNs, and CNAs, instead of using them as staffing agency, correct? As a board member of a hospital that we have been talking about struggling financial positions, why are we doing this?
They are, Cohesive Corporate is working on a new staffing model, incorporating the staffing nurses and the core nurses together. Hopefully, I think they're looking at that to be done in April on that, if I'm correct on that.
So, per month, we pay $141,000 to Cohesive staff.
Could be more.
Could be more, could be less.
Yeah.
People call it sick, we have an influx of patients.
Are these staff members, are they on an open-ended contract with them? They stay there, or is it like a 90-day?
They're on an open-ended contract with them.
Has this board entered into a contract with the staffing saying that a certain percentage of staffing must be done through the staffing agency?
Not that I know of. I'm not aware, I mean, if it was prior to me, because they brought on those during COVID, of course, because we couldn't get staff, like everybody in the nation could, and that was a fix to actually be less than a true staffing agency was to staff that work the facility. And it was a resolution for all the facilities, not just Mangum.
Yeah.
They were able to utilize this core across all those staffings, 5 different agencies, 5 different hospitals.
Now, is the definition of course, does that still mean, has that changed at all?
No.
Okay, so would you tell us once again what that is?
A core facility or core employee gets full-time hours, 32 and above, and they get all benefits, PTO, have access to health care. They get first, for core staff looking at scheduling, they get the first dibs at schedule, at their schedule they want. And then from there, it goes to our PRN, core PRN, and then it goes to the staffing agency after that.
So do we have local nurses who we are not getting their full benefit hours and they're forced to get other jobs at other facilities out of town because of this policy in place right now?
Hard to say yes and no.
I mean, it is embarrassing when I run into a nurse at the at a nursing home out of town. And I said, "What are you doing here?" He said, "I can't get enough hours at Mangum."
So does staffing agency nurses guarantee a certain
No,
number
they
of
do not
hours?
get guaranteed hours.
So are they the first ones called off if you have low census?
If they, yes, they are. They're the first ones. They are not, currently, Nick and I look at the schedule every month to look at overtime and who's getting overtime. Right now, we are limiting, unless we cannot get it covered, they are not allowed to get any overtime, unless something. Only core. We allow core to get overtime. So if a core nurse has 3 days and we have an open position or an open shift, we offer it to them first. If they want it, it's theirs. no matter what.
Speaking of core RNs, how many do we have, core RNs?
So in May, you're gonna have a whole new crop of RNs that will be RNs by June,
Yes, ma'am.
theoretically.
Correct.
And so when all 25, 30 of those are done and they go looking for jobs because they live in Lone Wolf, Granite, Mangum, Altus, they go looking for jobs, you're gonna tell them that you don't have any because your staffing agency nurses count as actual staff.
Currently, they do, yes.
Okay, is there a way to change that? Because they're really, I mean, you shouldn't be relying on staffing agencies if you have people who are wanting to be core staff. You should have core staff that actually have a vested interest in being at Mangum Regional and taking care of the patients that come through Mangum's doors, as opposed to someone who's not having a vested interest in that facility, because tomorrow they could be at Sealy
Correct.
or wherever else.
Yep, right. Husker, Carnegie.
Right, but the ones that wanna be at Mangum should have the opportunity to be here.
Or RNs or plus.
7 LPNs, the 4 RNs, we have one that we interviewed and will hopefully be, I think it was approved today, issue an offer letter, so that would be 5, so technically 5.
Full-time or is that?
So that would be 2 full-time RNs, with the other ones being PRN.
Okay.
Their court.
And then you said 7 LPNs?
Yes.
What's a
Their
breakdown
court.
on that?
9 RNs are considered technically staffing, so 7 LPNs are full-time. Well, I'll say 6 are full-time with 1
That are
being
core.
part-time that are core, and then we have 1, 2, 10 that are staff.
And that's LPNs.
And that's LPNs. And then we have 4 CNAs that are core with 1 being staff.
Wow.
Okay.
And the 4 are able to cover, because we have 1 per shift, so we have 2 AM for 2 days, 2 nights. And that covers the full schedule, with 1 available to fill in.
Yeah, this is just staffing, the rest of them are court.
Still seems a little high to be paying that much when you have that much core staff. But I know the staffing nurses get a lot more.
They get a lot more
But
power.
is there the ability to turn this over, I guess, within our current arrangement?
Yes. I mean, when we post jobs, I will say, I mean, again, when we post jobs, we get applicants. I mean, we do. When we post a position, we get applicants. If we post RN jobs, what, we can take a week to get an applicant, or a week to get a full-time
4 or 5
applicant.
others that could be.
Wow, yeah. So, I mean, the facility is getting applicants, so.
Yeah, because it all comes back. We need that for our city. We need that money to stay here.
Yeah.
Those people are vested here. We don't need that money running off to all other parts of the state when it's highly needed in our community.
And
That
for the health of the
reinvestment.
hospital.
The health of the
Yes.
hospital, the health of the community, absolutely.
Yeah.
Local investment's key to everything.
Do we have any staff remarks or any other staff remarks or board remarks at this time? New business,
Yes, new business. I would like to make a motion that we agree to the settlement funds being utilized to cover all outstanding legal fees.
Including attorney fees and costs.
Including attorney fees and costs.
I'd like to second that motion. We can call for a vote at this time.
Lively,
Yes.
Ford. Yes. Van Zant,
Yes.
Hopper.
Yes.
Any other new business? I'd like to make a motion that we adjourn. We could call for a vote at this time, please.
Lively,
Yes.
Ford.
Yes.
Van Zant,
Yes.
Hopper.
Yes.
Okay, this concludes the meeting of the Mangum Regional Medical Center today. Thank you and have a blessed day. Where did you get Dutch Brothers coffee?
I just recycled the.
Oh, I was like, wait, did something open up in Lawton or Elk
I
City?
wish, no,